So let's move on from anatomy to a little bit of physiology, specifically the mechanism of breathing. Now, I think we were probably all introduced junior high, high school to how the diaphragm affects our breathing. And so, like this diagram right here says, with inhalation, the diaphragm contracts and moves down, and with exhalation, the diaphragm relaxes and moves up. And if you're like me, you probably have thought that it's the diaphragm, or it's inhaling that changes the diaphragm, or exhaling that changes the shape of the diaphragm. But I'm going to have you kind of think of it in a little bit different way. It all starts here in the brain. And we've talked a little bit in class about the autonomic nervous system. The autonomic nervous system controls things automatically is a good way to think of it. And so that's why when we're asleep, we still breathe, even though we're not consciously thinking about it. It causes our heart to beat, things with our vessels, makes our stomachs digest. All kinds of things are controlled by the autonomic nervous system, including the respiratory system. So let's go back to this physiology of breathing. Okay, here I've drawn a really simple picture of somebody and their lungs, and these red dots really represent particles in the air, and you can think of these at the atomic level. All these particles are flying around, bouncing into each other, and as they bounce into each other, they create kind of a pressure. And so here I have the pressure is about equal outside the lungs as it is inside the lungs. You see how the little red dots are about the same space apart, and this represents what it's like when the diaphragm is somewhat in between inhalation and exhalation. Let me draw the diaphragm. Okay, so here I've drawn the diaphragm, and it's in blue. And here the diaphragm is actually constricted, so it's pushed down. And you see how now there's more space. There's all this empty space in the lungs. And so the air particles inside the lungs have more room. They're not bouncing around as much as the air particles in the outside. So this creates what we commonly call a vacuum. You've heard of probably the vacuum of space or a vacuum sweeper, kind of along the same concept. It just means that there's less bouncing around of atomic particles in this space than there is in this space. And so what it does is it causes things to move from outside to in, because air particles, they don't like to be crowded. So it's kind of like the cow thinking the grass is greener on the other side of the fence. The air particles think, hey, it looks better in there, it's less crowded, so let's move in. And so that's what causes inhalation, is the brain sends a message to the diaphragm contracts, it makes the space within the lungs larger, and so creates a vacuum, draws air in. Now let's change our diaphragm a little bit. So here I've added a little bit more to my drawing. So I have the brain with the medulla, which is the respiratory center. I've listed 3 different nerves here as the message travels from the brain to the diaphragm and says, hey, we need to breathe. Vagus nerve, phrenic nerve, thoracic nerve. These are going to become more important in the next unit when we talk about the neurosystem, and why when somebody has like a spinal cord injury, that if it's high enough up in the neck, that it can block this message and they're no longer able to breathe on their own. So we'll talk a lot about that in neuro. But anyway, you can see I've reshaped my diaphragm here. It got the message, it says relax, and so it does, and as it relaxes, it pushes up into this thoracic cavity, and now the air particles are more crowded. So again, they want to diffuse or move to an area of lower concentration. They don't like to be crowded, so they want to escape and go out into the atmosphere or the air, and so that's what produces our exhalation. So it really is all driven by the brain telling the diaphragm what to do, rather than the other way around, the brain telling us to inhale, which reshapes our diaphragm. Just a chicken and egg thing, I guess. Let's talk a little bit about the anatomy and physiology of the lungs, mainly what we're going to call this pleura. Pleura is the lining of the lungs, and we actually have 2 main pleura. We have the visceral pleura, and the visceral pleura is what lines the lung itself. So this kind of goes around the lung and it holds all those alveoli together. And then we have the parietal pleura, and the parietal pleura kind of lines the outside of the chest wall or the thoracic cavity. And so real simple analogy would be like if you buy some bread at the grocery store and your bread is contained within a bread sack. Then when you go through the checkout, they put your bread sack in a grocery sack. And so you actually have two sacks. So um, the visceral pleura is like your bread sack around the lungs, and then the parietal pleura would be the outer sac. And it's important to understand how these two work. This lung is showing how it's supposed to look. So there's supposed to be a little bit of space, and it allows the lung to move around without, it's kind of like filled with, you might think of it as like motor oil. And here we have a problem. This is called a pleural effusion, and this is where fluid has collected between the two places. So kind of like if you filled your Walmart sack full of water and then stuck your bread in it, that's what a pleural effusion is so there's fluid accumulating here. And what that does is it puts pressure on the lung, because again, your lung is mostly filled with air. And so as the pressure increases, it causes the lung to, what we might say, collapse. And so this is like when someone who's sacking your groceries and doesn't know what they're doing, and they put a bunch of soup cans on top of your bread and it smashes your bread all up. Well, that's kind of what a pleural effusion is when fluid accumulates in the space between the two pleura and puts pressure and collapses the lung. So again, I always thought a collapsed lung started with the lung collapsing, but no. What causes a collapsed lung is something gets in this space and pushes against the lung. It doesn't necessarily have to be fluid. It can also be air, and we call that a pneumothorax when there's too much air pushing against the lung here. It can be blood, and then we call it a hemothorax. But in this case, this is just a pleural effusion, so it's some type of fluid that's pressing against the lung. So it's important to understand that you have two pleura, because there's an awful lot of problems that can happen in between these two pleura. Before beginning a focused assessment of the respiratory system in your patient, it's important to understand what kind of changes we can expect to happen related to age. So here I've drawn a down arrow and an up arrow. So everything in this category are things that decrease with age. So lung elasticity decreases. The number of alveoli decreases, although we have way more alveoli than what we need. So under normal circumstances, this doesn't cause any harm losing some. Respiratory muscles get weaker. Chest movement decreases, which probably is because the respiratory muscles get weaker. Same with the effective cough. Our ability to cough effectively decreases, again, probably due to loss of respiratory muscle. And our exercise tolerance decreases as we age. On this side, increases, and that doesn't necessarily mean these are good. For instance, the work of breathing increases. That's not a good thing to have increase. It gets harder to breathe. Rib cage rigidity increases. So our rib cage is less willing to expand when we need it to. Risk of infection increases, and the bronchioles enlarge. And again, that's not really a good thing, thinking of the respiratory system. But for the most part, it is not normal. Again, when we talk about age-related changes, it's not normal for someone to not be able to breathe. Don't ever let yourself think that having COPD is a normal part of aging. It's not. We're not designed for our respiratory system to break down, and when it does, we consider that to be illness. When we begin our focused assessment, the first thing that we need to make sure of is that our patient is not in respiratory distress. If your patient is in respiratory distress, stop your assessment and take care of the respiratory distress. Nobody wants to be asked what medications they've been taking when they're having an acute asthma attack. So we always treat the respiratory distress first, and then the remainder of the assessment can come later. But assuming that your patient is not in respiratory distress, what is their chief complaint? Do they have a cough? Is it a new onset? Is it dry? Or is it productive? Dyspnea, that just means shortness of breath. Are they short of breath all the time, or just upon exertion? Dyspnea on exertion means sitting watching TV, they're not short of breath, but when they get up to go to the bathroom or try to cook a meal, then they get short of breath. And then pain, have them describe the pain. Is it pain on inhalation, pain on exhalation, or just pain all the time? Past medical history and family history. Allergies, and here we're going beyond any type of medical allergies. We need to know about seasonal allergies too. Have they had any trauma to the chest? What kind of surgeries have they had? And then here's the thing that takes a long time. What medications are you taking? Immunizations. Have they had a flu shot? Have they had a pneumonia vaccine? And then exposure to secondhand smoke. Now, smoking itself is considered part of the functional assessment, but exposure to secondhand smoke is really considered part of the medical history or family history. So they're a little bit different. But getting on to the functional assessment, occupational history, we're going to talk about one disorder, histoplasmosis, for instance, that it's a fungus that's found in the soil and in the bird droppings. And so if somebody is a farmer or works with poultry, then they're at a lot higher risk to have histoplasmosis than somebody who lives in a city and works in a bank. So occupational history is important. Also, we'll talk about what's commonly referred to as coal miner's lung. So different things can affect the respiratory system depending on your occupation. Diet and fluid intake, and then smoking history. And so again, smoking history is part of your functional assessment, kind of like the occupation, whereas exposure to secondhand smoke would be more history related. On our physical assessment, vitals, height, weight, that's going to be for pretty much any system. Beware of tachycardia. Sometimes that's an early sign of hypoxia. We're going to talk a lot about hypoxia. That means not enough oxygen circulating around. So tachycardia can be an early sign of that. We're going to check nares and sinuses. And one way to check the patency of the nares is to gently close one side off and see if they can breathe through the other side. Sinuses, when you press on the areas where the sinuses are, does it cause pain or tenderness? Cyanosis means a blue discoloration of the skin that can, again, indicate hypoxia. This is usually a later sign than that. I'll have a picture. Let's see. Here we go. Here's some cyanosis in this poor little baby. See how lips are blue? We're going to check the pharynx. Again, if you forgot what that was, that's the back of the throat. So that's where you have them open wide, maybe push the tongue down with a tongue depressor and look at the back of the throat. We're looking for redness, exudate, and if I see little white pustules, I'll send you home for strep throat, right? Trachea midline. This has been on your assessment that you're doing in clinicals, and a lot of students don't really understand why we do that. But I think after this unit, you will, because a lot of the problems that we're going to talk about can cause the trachea to deviate from midline. And like where I showed you a picture of a pleural effusion, anytime one lung is affected and the other's not, it can force that trachea to move towards the more inflated lungs. So a lot of times when we see that tracheal deviation, that tells us that something's wrong with one of those lungs. We might have a collapsed lung on one side, or maybe a collapsing lung or a pleural effusion or something like that. It's going to cause that trachea to deviate from the midline. Breathing patterns and efforts, and that includes respiratory rate, which is part of your vital signs, but how difficult is it for them to breathe? Are they using accessory muscles? That's something you're going to see a lot. And here's some of the accessory muscles I'm talking about. Sternomastoid, scalenus, trapezius. Normally, you shouldn't see these move very much when someone's breathing. When someone's having to use their shoulders to help them breathe, that means they're having some problems. Now, the diaphragm is not considered an accessory muscle. That's your main muscle of breathing. But these muscles right here, these are accessory muscles, and the use of those tells us that somebody is really having a hard time breathing. So that would make them have a lot of effort to breathe. And then finally, we're going to auscultate the lungs. And I know students hate this, and it just takes practice. And the more normal lung sounds that you hear, the better you'll be able to notice when somebody has abnormal lung sounds. If you look in your textbook on page 562, it will show you all the places that we should be auscultating the lungs and the different sounds that we might hear. Lastly, the circulatory system is really closely related to the respiratory system. So here's some things that we might see that relate to the respiratory system. Fingers for clubbing. There's a picture of that, and mainly that just means that the end of the fingers look really spoon-like. And the cause of that is not really agreed upon in the medical community. Obviously, it has to do with increased venous blood flow, but no one knows what causes the increased venous blood flow. But we do know that there is a correlation between clubbing